everybody. Welcome back to the Journal Club today. Today we have a very exciting session discussing real hot topic in the field of structural heart disease. So it's a real pleasure and a very warm welcome to Alessandro Sticchi from Bern in Switzerland, who will be discussing this latest article about the Intrepid early feasibility results. And a very warm welcome and a real thank you very much, Professor Maisano, for joining us once again for the Journal Club. We all really appreciated when you joined us last time. It was a fantastic session together, and it's a real pleasure that you've joined us back again, especially so early in the morning. So, Alessandro, if you can start, and we can then have question and answers and discussions at the end.
Absolutely. Thank you very much. Thank you very much, Arif. It's a great pleasure to be here today, and really an honor to have as a special guest, as expert, Professor Maisano. We're going to talk about the results of the Intrepid valve experience, the 30-day results of the early feasibility study. As we know, the treatment of mitral regurgitation is becoming really an important challenge because we have more tools, and it is becoming every day a more complex scenario. We have an heterogeneous clinical and anatomic population, and TR has demonstrated beneficial outcomes in prohibitive high-risk primary MR and in selected functional patients. Severe MR patient categories have not been studied, and optimal MR reduction with TR remains a challenge, especially in complex anatomies. Numerous studies of surgical and transcatheter therapies demonstrated how important it is to achieve a durable and consistent MR reduction. And this is very important for the outcome of the patients. And TMVR, the transcatheter mitral valve replacement, such as the Intrepid system, may be a treatment option for patients unsuitable for TR. We know that the prevalence of DMR is increased, and also that we have really heterogeneous patterns of mitral disease. We have prolapse, commissural prolapse, annular dilatation, rheumatic mitral stenosis, restricted leaflets, and also, of course, a mix of all these diseases. And we know that is very important, the residual MR for the outcomes, to have good outcomes, because the recurrence of the MR in both primary and secondary MR, as you can see, have several severe consequences in mortality and also in heart failure hospitalization. And for the several studies, the several registries and trial in the past, we know that it is not so comforting, the mitral regurgitations as outcome at 1 year. As you can see, only in the expand registries, that is the more recent, with the last technology, we can achieve a better result, but is still not enough. So we have several patients as candidate for TMVR, and so we trust in the promise of the TMVR for to be less invasive than surgery, with the predictable and durable elimination of MR and easier to use. We talk about the experience with the Intrepid valve. As you can see, it is really a large experience with more than 300 patients treated with transapical and recently with the transfemoral approach, and with more than 5-year follow-up. We are focusing on the future direction of this program, the early feasibility study with the transfemoral approach, still with the first generation of device. And about this experience, this population, these single arm trials, the Apollo 1, we are talking about prohibitively complex TR anatomy, and still patients that are unsuitable for surgery, and so both for TR. We are talking about the results presented at the 30-day outcomes presented at the TCT from Faria Azar, and we have first to look at the device. The Intrepid TMVR delivery system is a transfemoral access with dilator and a 35 French sheath, so quite a large size device with cradle and delivery catheter, familiar transseptal maneuvers, and the valve, as you know, is a conformable outer stent anchors without leaflet capture, symmetrical design that eliminates the need for rotational alignment, a circular inner stent with 27 millimeters to leaflet bovine pericardial valve, and we have two measures now, 42 and 48 millimeters valve, and there is a larger size under development, and identical valve design from the transapical system. The results that we are going to see are collected from 6 centers in the US, and this is a prospective multi-center, non-randomized early feasibility study with the clinical and echo outcomes according to EMBARK criteria, with an external physician screening committee, protocol specified echo acquisition reviewed by an echo core laboratory at Mayo Clinic, and an independent CEC adjudication of safety events. About the criteria of inclusion and exclusion, we can see for the inclusion, at least moderate, severe symptomatic MR at high or extreme risk for mitral valve surgery, adjudicated by the local heart team, and with an anatomy suitable for the Intrepid TMVR transfemoral delivery. As exclusion criteria, life expectancy less than 1 year, anatomic contraindications for Intrepid TMVR, severe prohibitive MAC, and severe TR or RV dysfunction. About we know that 26 patients were reviewed by the screening committee. Few patients were excluded for access issue from frozen posterior, one from frozen posterior leaflet, and 2 patients for the withdrawal of the consent. 20 patients has been approved, 5 waiting for the implant, and 15 patients undergoing the procedure. And of these patients, we had the success in all of them except one. In this patient, there was a conversion to sternotomy during the index procedure, according to what we know, the investigators said that there is a significant thickness of both the leaflets and the subvalvular apparatus. And so after a few minutes from the implantation, the valve migrated in the atrium. And so it was a necessary conversion to sternotomy. And we have of this patient the 30-day follow-up. About baseline characteristics, a mean age of 80, most of the patients are male, an STS score of 4.5 or 4.7. Most of the patients were in NYHA class 3-4, and the alpha were diabetes, 40% of patients with pre or heart failure hospitalization. And as you can see from the etiology, almost the 70% of the patients as primary MR. About the procedural characteristics, we can see that the most of the patients implanted the larger valve, the 48 millimeters valve. In the 70% of the patients was necessary the ballooning of the septum to pass the delivery. And the majority of the patients were discharged at home. Another important characteristic that we have to focus is the septal closure in the 70% of the patients. So the successful implants was achieved in 14 patients with, as we said, just one conversion to surgery, and the patient at the end of the surgery was safely discharged. The clinical outcomes. So we have no mortality, no stroke, no reoperation or interventions, no pacemaker implantation, and no acute kidney injury with a stage more than 2. But what is the main issues of this study? The vascular bleedings. Major bleeding events defined according to the EMBARC criteria, and they are major vascular complications. And one hospitalization also related to minor vascular complication. The 30-day outcomes echographically are very, very good. As you can see, the mitral regurgitation was completely resolved at 30 days with all the patients that has known or trace malregurgitation. The same we can say for the paravalvular leak. We have no or trace paravalvular leak at 30 days. And also about LVOT obstruction, there was a few percentage of patients with LVOT obstruction at the discharge, but they went very well at 30 days. And about functional outcomes, as you can see, more than the 80% of the patients are in class NYHA 1 or 2 at 30 days. So in summary, the 30-day data from the Intrepid TMVR Transfemoral Feasibility study demonstrated no mortality, stroke, or intervention, so good outcomes. But around 50% of patients had major bleeding events, and they are due to the access site, major vascular complications. But we have also febrile hemodynamics with almost complete elimination of MR at 30 days and improved in functional outcomes. We can say that the procedure, according to this data, is feasible and potentially provides a straightforward approach to eliminate MR. So some observation, a febrile durable procedure, improved 30-day major clinical outcomes compared to the transapical experience, but still some limitations that we summarized here, also considering the very, very interesting editorial from a colleague Herrero and Riara published with the manuscript. Vascular complications. These complications could be related to the anticoagulation bridge therapy. So anticoagulation, we need a standardization pre-procedural, during the procedure, and post-procedural. A learning curve with the system. We have a large bore due to the size of the device and the need for cutting for a surgical cut down. The valve alignment was a concern, but because we know that is more easy to achieve with the transapical approach, but still the transfemoral transseptal show to guarantee a very good alignment, except for that one case that we know that we said. And also transseptal complication. Yes, the larger residual iatrogenic SD could lead to worsening volume overload, or failure decompensation, and a right to left shunt. And we have to consider also lifelong MR management. Closure of the ISD might impede future access to the left atrium. So other future procedures such as the PVL closure or the LAAC, the closure of the appendage, but also other procedures. And the relationship in the editorial, they suggest a relationship between the shift size and the need for closure. There is, we are collecting, we can say, a nice experience with the valves, with the new generation of valves, but still we need to improve, and that's why the technology is helping us, because the second generation, as you can see, of the Intrepid system has a 29 French. That is, of course, an improvement from the 35, and we will cover also the patients with the larger valves, with the 54 valve. So we have a discussions. We could have a nice discussion. Now we have really a great expert, Professor Maisano. I collected some questions to ask to him. The very first is we can comment the impressive results of the Intrepid study. Thank you very much.
Great. Thank you so much, Alessandro, for that summary and overview of the article. I think, Professor Maisano, if I could kindly invite you to, perhaps we can start with the first discussion point that Alessandro's raised about their impressive results in terms of procedural outcome with the Intrepid device.
Thank you, Alessandro, for letting me read in this paper. I didn't read before, so it's always good to join a journal club because you watch the data at the meetings, and if you look at the paper, you find a lot of interesting issues. Well, impressive, yes, excellent, good start, but you know there is much more behind the curtain than what has been shown in this paper. First of all, let's start with the suitability for this procedure. This paper reports 30 patients, something like 30 patients who have been found, actually less than 30, 26, I think, found eligible. Of those, 6 have been selected. Of those, 15 have been implanted. Well, this is the main issue here. This valve is very small, requires some degree of oversizing. And so one question arises about eligibility, and in this paper they don't report how many patients have been screened to find these 26 eligible. Yeah. The other thing that has to be very well recognized, that this is a so-called high-risk population. Actually, it's not a high-risk population because the average STS risk score for surgery replacement is 4%, which is average, or let's say not high-risk population. The ejection fraction mean is almost 50%. A typical population for this early feasibility studies in valve replacement. I want to really highlight this feature specifically when we discuss repair replacement, because one of the, you know, there are already now two parties, two political parties, two religious parties, one which is waiting for replacement, one which is really still protecting repair, but these are not the same population, and it's a completely different case mix. I would like to now just quickly go over the outcomes and share with you also my personal experience with Cardioval, which is another transfemoral transseptal device. The first thing that I would like to mention is the high incidence of vascular bleeding, which is astonishing, but not for me. Actually, it's 50% of patients, more or less, have been experiencing a vascular problem. In the study, it is clearly shown that this is patients have been vein has been prepared surgically, and this was also our experience with Cardioval. We switched from totally percutaneous to surgical cut down, because there is a huge difference when you upsize from a 24 device, which is a typical mitral clip approach, to a 28, 29, and in this case 35. So Cardioval is a 29, and still we have a lot of problems. So vascular access, for even vein vascular access, is an issue, and part of the screening process is also regarding the size of the vein, and maybe that some of these patients have been turned down for that as well. There are another technical issue is balloon dilation of the septum, which is to me also a bit funny to see that only 73% of patients, so it means that probably in 2-3 cases they push the device inside. I don't see any reason to do that. But anyhow, it has been done like that. And closure of the ASD is a question of discussion. We can discuss maybe all together afterwards. But in my experience, I decided to close them all at the end of the procedure. Finally, two let's say not unexpected but rare complications. Sorry. One is LVOT. LVOT obstruction is in the paper is reported some moderate LVOT obstruction in 2 patients, and moderate I think is a bit pleonastic because these 2 patients had 50 millimeters of mercury, one of the 2, and the other one was 38 peak systolic. So we're talking about pretty significant LVOT obstructions. In one patient, this LVOT obstruction disappeared. But this remains one of the issues with replacement, and specifically with some devices. And this is one of those devices which may have higher problem than others because of the shape of the device and the way this device is actually fixating itself in the anatomy. Finally, air embolism. One case with myocardial infarction, so probably some troponin, whatever. This is a very underestimated issue with all our devices. And I'm just starting to collaborate with a company which is producing a system to de-air large devices, which is something we don't do in our procedure. We do it, but we only use a simple flushing. In vascular surgery and in vascular interventions, they have a lot of steps before they introduce these large devices. And this is probably will become a new topic in the next future. So overall, conclusion is how do I comment these outcomes? So these are very early outcomes. Good news, there was no mortality. I would be very, very careful about valve replacement overall. And as a matter of fact, as you know, there are much more tricuspid replacement than mitral replacement, and there must be a reason.
Okay, thank you for sharing your insights and experiences. So I'd like to take a couple of questions from the chat, Prof. The first question is about antithrombotic therapy. So what is the conventional regime, given it's a bioprosthetic valve, especially as we've seen quite a strong signal of bleeding in this particular study? What is your feeling about anticoagulation, and what is your personal experience?
You know, with transcatheter valve replacement, we have seen a number of patients developing early signs of thrombosis and kind of halt signs. So we have to give anticoagulation to these patients. Actually, whenever possible, we also combine an anticoagulant and antiplatelet agent in the same patient. But for sure, we keep patients anticoagulated for 6 months at least.
Okay, thank you. Then there's a question about patients who have, let's say, atrial mitral regurgitation or AF associated quite extreme annular dilatation. What is the best treatment strategy, either repair or replacement, for these patients in your experience, or what seems to be the best? Is there a replacement device that's suitable for these patients?
First of all, we don't know for many reasons, because first reason is that we don't know much about atherogenic AFib. This is something new which is coming to our attention. There are some studies now specifically focusing on this subgroup of patients. Actually, there will be soon some data from the EXPAND registry, specifically on MitraClip, show that atherogenic MR is also a good target of therapy, but we have no data regarding the prognostic benefit of patients. The only thing I can comment is that atherogenic atrioventricular valve regurgitation is probably the best indication for annuloplasty in the future. At the moment, you know, annuloplasty is on the side. I was yesterday with Edwards. They still see other shortcuts, you know, Pascal and the replacement system and Evoke. And probably they will come out with generation 2 Cardioband. Hopefully will be better. I don't know, because I'm not at the moment working with them. But I think annuloplasty will come back sooner or later. And these are the patients where this works best. When it goes to current platforms, replacement could be a problem because of the size of the annulus. Usually they have an annual dilatation.
Okay, thank you. And then there's one question, a lot of, let's say, young interventional fellows, or let's say early career interventionists. You mentioned earlier something about a difference between the repair population and the replacement population. And if you had to sort of summarize the two profiles of these type of patients moving forward. So when young fellows come across these patients in clinic and outpatient, in your head, how are the two populations different?
So at the moment, we have in most high volume centers, replacement is considered in those patients who have an anatomical feature which is unsuitable for repair. The reason is very simple. Repair is very safe, is off the shelf. It does not when we talk about repair, we're talking about transcatheter edge to edge. Be very clear. There is only one very available device, which technique with at the moment 2 devices, MitraClip and Pascal. Maybe in future we will have Dragonfly from China, whatever it is. But transcatheter edge to edge repair is versatile, safe, available off the shelf. You don't need any specific pre-procedural screening. Almost all comers are treatable. And we have been treating extreme patients with ejection fraction as low as 10% with acceptable outcomes. I'm not saying that these are good candidates, but you can treat almost everybody. We go into replacement, the trials are very selective. As you see, mean ejection fraction, 50%. STS score, 4%. This is the same for every study. If you look at the Tendine study, it's the same. So these are not comparable populations. And as we move forward, why this is so? Why the trials are enrolling such a cherry-picked patients? We know that replacement is associated with 2 things. On one side, it is hemodynamically ideal. You solve the problem. On the other hand, this is also a problem because if you solve the problem in a patient with the LV dysfunction, you may have afterload mismatch, and this is one of the problems. And also, when you replace the valve, you rely totally on the device, which means if the device is upside down, the patient dies. If you implant a clip in the wrong position, you may have more MR, but the patient doesn't die. So again, in terms of safety, repair remains much higher value, and this probably will influence the prevalence of the 2 procedures in the next years.
Okay, thank you. I believe we have one last question on the chat, and that takes us to time, about the role of pre-procedural planning for replacement procedures. I know there's a lot of screening involved with companies and CT scans. If you could just share your thoughts on that, please.
You see in this picture from Alessandro that Nico Piazza is showing me some CT scan, and I look at the CT scan a little bit worried, whatever. So CT scan is the screening modality for replacement for a number of reasons. So a number of factors are involved in the selection of these patients. First of all, the size of the valve. This is the first thing you watch for. The second is the presence of calcification, which is in most occasions, for most valves, besides tendine, is a contraindication. The third thing you want to look at is the size of the left ventricle and the risk and the anatomy of the LVOT. Basically, you have to predict the virtual LVOT that you will obtain after you implant the valve in position. And last but not least, you look somehow at the at the overall anatomy for the axis, because you need to watch for the position of the fossa, the size of the veins, and so on. So you can't do these procedures. You cannot do these procedures without a CT scan, and you cannot perform a transcatheter valve replacement without a very well done echo and maybe right heart catheterization to be sure you rule out those patients who may have a risk of developing a
Okay, that's great. So I think that takes us to time. It just leaves me to say a big thank you, Alessandro, for joining us and presenting the paper and summarizing a real hot topic. And Professor Maisano, on behalf of all of us fellows who connected today and also in the future, thank you very much for joining us once again. You really enrich our discussions, and we really appreciate you spending your time with us. So thank you. We hope to see you back again, and certainly for some of us, see you at London Valves.